Okay, Chapter 3, Principles of Drug Administration. What we're really going to talk about in this chapter is nurses have to have a real comprehensive understanding of what they're giving and who they're administering to really limit how many dangerous side effects happen. We're going to look at the 5 rights as far as safe drug administration, and that's something that should be of review to you. And recognize that it's a health team approach. For compliance, we have to understand that all of our patients need to know all the information that we can provide to them about drug education and how to take it, the importance of taking it, and what really happens if they don't take it. We need to understand why it is they don't take it. We also are going to talk about just established orders, how to give meds, time schedule wise, different measurements that are going to be used as far as different routes, those kinds of things, everything from oral to IV, etc. So we'll proceed. So I'm going to skip through NCLEX on as I go over this. I believe okay, nurses really, because we are ultimately the one who is giving that med, as we've discussed previously, we are the ones who are ultimately responsible. If there's an error, regardless of whether it is a written order that was written incorrectly, the pharmacist who filled it incorrectly, ultimately our primary role is to ensure that they are delivered in a safe manner, and it comes back down to us if that isn't happened. Before any drug is given, we basically need to make sure that we have an adequate assessment of the patient, a history. We need to know what kind of disease processes are going on with that patient. We also need to know enough about our patient to know what their learning needs are and what they're actually able to understand. Language might become an issue here as our growth and development level or even cognitive level. So you have to take that into consideration. It does me no good to give someone who can't read a pamphlet to go over what they need to do and look for when they go home if they can't read it. So I need to provide information for them that's going to be pertinent. Nurse responsibilities, no classifications, actions, and side effects of the drug, no patient details. Why are we giving this patient this drug? We have several drugs that may be given to a patient that could be given for a number of reasons. 2 drugs I like to use the best example of are Benadryl or diphenhydramine, which may be given for any number of reasons. It may be given as an antihistamine because clearly that's one of its biggest uses, but it also can be used as an antiemetic or anti-nausea drug. It also is used as a sleep aid, so we need to know why it is that patient has been prescribed that drug for what purpose. The other med I like to use for an example there is aspirin, and the reason being, originally aspirin was given as a pain reliever or an antipyretic or to bring fever down, and in all reality it's probably given more these days as a cardiac med, a blood thinner, granted in a much lower dosage than what was given as a pain medication. But we do need to understand why a drug is prescribed. We need to know how that drug is acquired in pharmacy procedures. We'll talk more about controlled substances in the future, but as far as scheduled meds that are narcotics have to be acquired in a certain manner, and we need to know how our patient is going to acquire them likewise. Need to know how to prepare, and we need to know how to administer that drug safely, and if we have to reconstitute that drug or it has to be prepared with another kind of solution. We often reconstitute Rocephin, for example, which is an antibiotic, with lidocaine. So those things understand. Before drugs administered, nurse must know all the variables of the client's condition. And given the time elements that we have, we do not necessarily always know an awful lot about our patients before that, but it is our responsibility to be aware of that client's history and condition so that we know that we can safely give that. Are they on another medication that might have a problem with this drug that we're preparing to give them? We also need to recognize and react to adverse effects and be prepared to do so. So in doing that, we have to know what a drug's side effects are and able to do that. 5 most common medication errors, and we talked about this in PVC with one of the projects. Incomplete patient information. We don't have all the patient information or history. We may not know about the drug as well as we should, and that's really ultimately our responsibility to look up. In the day and age that we live in, there really isn't a lot of excuse not to have that because we have so much online information. Miscommunication of drug orders often can be when for example, a verbal order is often miscommunicated. A lack of appropriate drug labeling is another. Things aren't labeled appropriately, dosages aren't transposed appropriately, and environmental distractions. And we talked again about that in a project where there's discussion about having a safe area or an area that isn't full of distractions for nurses to be able to fill those drug orders so that they aren't interrupted and make foolish errors that they might not otherwise. Allergic reactions are basically a response by the body to a foreign substance. We see allergic reactions to all kinds of things environmentally, but clearly they can happen with a drug. And what often happens is each sequential reaction tends to be a little bit more severe. So one time they might just have itching skin, and the next time it may progress to a full-blown anaphylactic shock, which is a very severe systemic kind of reaction, involves a histamine response. And usually the thing that is of most concern for us is the fact that they often have severe swelling of their airway, dyspnea, and they can also have subsequent hypotension and tachycardia. But the big issue is often their airway becomes a problem before anything else. So we really need to know that. It's critical that we know patient allergies prior to giving a medication. Our hospitals are going to have special bands that are going to give us that information. But if we don't have, if we're in a clinic setting, for example, they aren't going to have those bracelets, and we're going to need to review that patient chart and even question the patient as far as their common allergies. The 5 rights that we're going to talk about, and you'll see us actually add another one as far as the documentation being the 6th right. So the right client, right medication, right dose, right route of administration, and right time of delivery. I think, you know, we've discussed that you can often just look at the order and pick out those elements and come up with those, but those are, anytime we give a med, our expectation is that those are reviewed. Again, in the age of electronic medication records, it's still our responsibility to ensure that we have the right client. Having the right client does not mean that I just scan their armband and say, yeah, that's Joe Smith. I need to ask him that it's Joe Smith. I ask for another identifier, typically the birth date, in order to do that. Right medication is always about reviewing it. You're going to review it when you pull it. When you look at it on the MAR, you're going to review it when you pull it from the medication area, usually a Pyxis. You're going to review it as you're preparing it, and then you're going to review it again as you are at the bedside giving that medication to the patient. Right dose, we're going to verify again with the MAR. We're also going to look up and make sure that that dose is appropriate if it's a medication that I am not familiar with particularly, and is this an appropriate dose for this patient? The right route of administration, is it being given, because you do have meds that can be given a multitude of ways, and that's clearly going to have a different effect. So is it PO or IM or IV? And am I giving it at the right time? We'll talk about timing in general, but that's critical as well, that it's at the right time of delivery. Typically within an acute care setting, we have a 30-minute window on each side of whenever that medication is ordered in order to give that. Your book talks about 3 different places to check. I think more is merrier always. Checking the drug at the MAR, again, checking the drug when preparing it, and then checking it before administering it. I want to make sure, even though our pharmacists are smart people, when I pull that out of my Pyxis, I need to make sure what I'm pulling out of that Pyxis drawer is exactly what I want. And so we review it very much when we're pulling it from that storage area. As we're preparing it and pouring it, we should be making sure that we have the right drug again, and should I need to look it up, that would certainly be the time that I want to verify that. Checking the drug before administering to the patient at the bedside, again, is critical. With an electronic system, that is automatically done, but it still bears our follow-up with the human element in checking it, because sometimes the computers are down, so you have to stay in the habit of doing that. Mistakes and liability. Mistakes happen. They happen far more than we really want them to. And again, ultimately, it's our job to make sure that drugs are given safely. Other places are going to be looked at, but if we ultimately give that medication, it's going to come back to rest on us. Drug compliance is basically, is the patient taking the medication the way it was prescribed? And clearly the patient has an active role in that, but a lot of it, I think, has to do with, are we doing our job as we should? And by doing that, I mean, are we educating them well? Do they understand that? And is there further information that we need to provide for them? Oftentimes, we have to find out, if they haven't been taking it, why is that they haven't been taking it correctly? Is it because they don't understand how to do it, or is it because they don't have the co-payment to go and purchase that drug? So we need to. Factors that cause a patient to deviate: the cost of the drug. What we think may be a reasonable amount of money, it really depends on the patient, because a few dollars for somebody who's on a very fixed income can make a big difference. And so, you know, oftentimes we'll have folks that maybe $4 for a copay doesn't sound a lot to you and me, but on an elderly person who is on a fixed income, that just is really a burden. Forgetting doses, they forget to take it. They take too many. You know, when we look at antibiotics, it is clear that we have a lot of antibiotics that don't get finished, and a lot of that has to do with patients forget to take doses, and then really ultimately they just quit taking them altogether. Annoying side effects, maybe it makes them nauseous. Blood pressure meds sometimes cause some unpleasant side effects as far as impotence and things like that. So there's lots of reasons why people don't take medications. Self-adjustment of doses: if one is good, well, 3 must be better. And I can take 3 in one day and none the next. Fear of dependency usually comes from pain meds. And there's a real issue with that, with people believing that their meds, they're going to become addicted to a medication that they've been prescribed, particularly like in a post-surgical situation, when in fact they need to understand that as long as they're taking that for the prescribed time, that's a very unlikely thing to happen. So we need to, again, be really questioning our patients as to why they aren't taking a medication, and, you know, is there something that we can do about that? There's all kinds of programs out there with pharmaceutical companies in general for those who are of financial need. A lot of our free clinics, our low-cost clinics, have access to some of those programs. And oftentimes, if someone is in real financial need, doesn't have insurance, or just has some issues as far as getting that medication, pharmaceutical programs will often have programs, or companies will often have programs that they can subscribe to and be able to get those medications. Stat order is going to be given ultimately immediately, but it's given only once. It should be given within a 5-minute interval. So they need to get that medication within 5 minutes of that order being written. ASAP, as soon as possible. Drugs should be available for administration within 30 minutes. So that's a little larger window of time. PRN administered as required by the patient's condition. So oftentimes they will have it say PRN for pain or nausea or some symptom that basically needs to be met before that medication is given. Oftentimes you'll have some assessment that goes along with that medication within the MAR that you have to go in and put in as you're doing a PRN med. For example, a pain scale that then you would have to go back and reevaluate later to document that, yes, in fact, that medication was necessary, and likewise, when it was given, it actually did some benefit. Okay, drug administration abbreviations, and these just take memorization, guys, and you just have to become familiar with them and use them and put them to memory. This would be something that might be helpful for you to make a one of the cards that you put in your pocket at clinical, a procedure card, if that's something that you're struggling with as far as memorizing. But these should be pretty straightforward. Abbreviations we don't use. Joint Commission has said not to use QD, QHS, or every bedtime, every other day used to be QOD. So again, these things tend to be written out now instead of abbreviated because they've been misunderstood too often in the past, and there's been too many errors that have happened. So, single order is a drug only to be given once at a specific time. Orders not written, stat, now, PRN, are just called routine. A standing order is often an order that is on a unit that, for example, on a pediatric unit, you would have a standing order for a Tylenol order appropriate for weight of a child with certain criteria, such as a fever or pain, that could be given at the discretion of the nurse should that that symptom be present. What's really critical when you're giving medication with a standing order is that you ensure that indeed that criteria is there and that those are met. And the only reason the only way you're really gonna reinforce that that is the case is that you have charted that those symptoms are in fact in place. So if you give a PRN order, it is critical that somewhere in that record somewhere, whether it's electronic or paper charting, that you have that symptom there. Drug orders have to be reviewed by the physician within specific time frames, so every 7 days. Drugs need to be administered during or between meals. Sometimes they We have to give them medication with a food because of it needs to happen for the buffer on their stomach. Likewise, some medications are better off given in between meals. For example, if I have an iron order to be given ferrous sulfate, that's often recommended that it be given in between meals because it is absorbed more readily if that happens. It's also supposed to not be given with milk, so that may be something that you see. Central nervous system drugs and antihypertensives are usually given at bedtime. You often see things first thing in the morning or right before bedtime given. So you need to be aware of when something is to be given. The other thing that your book points out is some religious compliance that you may have some issue with. If you have certain folks that are fasting, taking an oral drug may be an issue. So you may need to look at when that can happen that is going to ensure their compliance more readily. Again, education is critical about when they take it because oftentimes that's something that they have trouble with. So making sure they understand that and repeat that information back to you is pretty critical in the whole teaching process. Nurses have to document the details given to patients after they've been given. If they tell you that there's no way on God's green earth they're going to take this medication, then you need to make certain that you document that in their record, that they have stated that. With that said, oftentimes we can find out why it is they aren't taking it and work around that. Maybe it's because it's the taste or, again, some side effect that we can work with. 3 systems metric, which is the one you're probably most familiar with. Apothecary is the oldest. It's not used quite as often anymore. And we have to incorporate household measurements because a lot of our folks want to still use their household teaspoons, etc., in order to give medications. I did a teaching session one time with a bunch of Hispanic women, though, and I pulled out like as many different spoons as I could find in a drawer just to kind of relay or make an impact on them how different each one of those is when they're giving what they think of as a teaspoonful of medication. You and I know a teaspoon by our standards is 5 milliliters. However, when they've got 15 different spoons in their drawer, they need to understand how important it is that they use a measured spoon that has that milliliter increments on it. I think what's also helpful is to literally give them a syringe or some type of a measurement tool with whatever drug that you're giving them and use a Sharpie and mark it on there so that they have something very tangible to take with them. Joint Commission does have a do not use as far as, again, the apothecary measurements. Nurses have to make sure that, again, we're having them use accurate measuring mechanisms at home. Quite personally, I think the easiest way to do that is to give them one to take with them. It's hard for them to mess up if you give it to them and you mark it and you actually show them and they can show you again in a reverse demonstration that they understand how much medication they're supposed to give. So I think, that's a good way to get around them using those devices at home. Here again are metric, apothecary, and household measurements. This is really about just memorization. So I'm going to suggest that, again, if this is something that you have a difficulty with, that you put this on a card and carry it with you. Okay, routes of administration. We've already you've covered some of these already in Funds 2, so I'm not going to get too in depth. Obviously, with all things, we have to review the medication order, wash hands, use gloves if it's indicated, and even with some oral drugs, it's absolutely indicated that you should use gloves. Identify client, check for allergies, whether it's in the chart, look at their armbands. We're going to tell the patient that we're going to be giving him this medication. I like for them to know that I'm coming back or I'll be in at X time to give them their medication. If it's a PRN medication, particularly if it's something that is for their comfort, they want to know that you're going to be right back and that you're going to basically relieve whatever symptom they're having. Position the client. If it's an oral, the more they can sit up, the better. If it, as long as their condition warrants it. We never walk off and leave meds at the bedside. We want to ensure that it is given. We don't document until it is in fact given. Some nurses have a bad habit of going ahead and documenting that it's been given, even though they haven't actually given it to their client yet, and that's a bad practice. Enteral route by mouth, tablets, nasogastric tube. We talked a little bit about that when I was showing you the nasogastric tube. You have to look at whether that medication, obviously tablets and capsules, some can be given via nasogastric tube and others can't, whether they can be crushed. If they're an extended release, they can't be given in a crushed form or can't open the capsule. If it's enteric coated, that's another something that can't be given. We also look at some sublingual and buccal routes. Those are very vascular areas, so those are going to be areas that medications are going to be given that are going to be absorbed rather quickly. One that comes to mind real readily as far as sublingual is nitroglycerin. We only want to give sublinguals after all the oral meds have been given and they've been swallowed. But recognize that when I give a sublingual med, I'm going to see a pretty rapid response from that. For the most part, on tablets and capsules, in general, we're going to think about a 45-minute window as far as when that's going to take effect. So I have to, again, note that if I'm giving meds this way, one thing about giving meds this way is what we call the first pass kind of issue. If I give meds via the GI tract, if it goes into the GI tract, some of that medication is going to have to first travel to the liver. And so it may not be as active as it would be if it were given in another form. Basically, some of it, if you will, is lost in the liver. And so, it may not have the same effect as if that drug was given in some other route. And again, that has to be considered. Enteral rate, again, sustained release are about part of the reason that many meds have gone to sustained release is because people have trouble taking meds several times a day. So if we can, if they can have a drug that's given in a sustained release tablet, they may only have to take it once or twice a day, and that's going to basically hold them through the whole day versus having to take it every 4 hours. The downside to that is we can't give that in the same, crushed manner as we could if it were a general, just oral med. So again, it has its upsides and sides. Here's your enteral rug administration. We obviously can only give meds PO if we have somebody who is alert. Now with an NG tube, that can still be given if they are positioned such, but with an NG tube, they're going to be usually at least a semi-Fowler position to prevent aspiration. So you would always want them to be at that angle to do that. If it's sublingual, they're going to place that under their tongue. They should let that dissolve completely without chewing or swallowing it. And then we want to make sure that that's in fact happened. Buccal route, again, they have to be alert and able to do that. They're still, like sublingual, instructed not to chew or move that around and allow that to basically dissolve completely. Nasogastric and gastronomy, hopefully we have it in a liquid form anytime it's possible in order to avoid clogging the tube. We're going to, first thing we're going to do always is to check for placement. Okay, that's going to be huge. So we're going to check for placement, and by auscultation, if you remember, we put it right under that left costal ridge over the stomach area, and we're going to insert about 15 to 20 mils of air into that NG tube and listen, and we should hear that, in fact, we hear air movement in, it almost sounds like flatus, in that region where we're listening. So once I've verified placement, if they have tube feedings, that's going to be turned off for the time period. In general, if they're on feedings, we do check for residual. That's a whole course of steps. If they have feedings going, we have to ensure that there's less than half in their stomach from what they received as far as a tube feeding, but that'll vary according to agency. We flush that NG tube first, and then we give the meds, often again with some solution, and give by gravity, so holding that up above the area of insertion. And again, we keep the head of the bed elevated, usually at least at a semi-Fowler's for an hour, to prevent them from aspirating, and then we can continue their tube feedings. We should flush basically before and after any meds are given in that NG tube. We've talked about the sublingual and buccal route, so I'm not going to go over that again. And this is just of the buccal. The nice thing about enteral is that it's convenient. It's often the least costly. We can actually retrieve medication. I mean, we can induce vomiting and cause them to, we can give activated charcoal to inactivate what's in their stomach, but we can also induce vomiting with like Ipecac and cause them to give up, if you will, some of that medication. It is the safest route. It takes the most time to take effect, so with that we have some time to work with. Disadvantages: some people really have issues with swallowing. Obviously, if we have somebody who is not conscious, that's not going to work well. We have a lot of enzymes within the digestive system. A lot of the stomach acids can work pretty heavily on medications. If they aren't having much motility, if they have constipation, or for some reason they have, say, a blockage in their GI tract, that's not going to work well. And again, that first pass metabolism in the liver, we lose basically a portion of that medication. Topical drugs are applied basically to the skin or the mucous membrane, so we can do it either. I think the most common ones we think of are skin creams and those kind of things. Installations or irrigations, any body cavities. So, for example, an enema or a douche might be considered. Inhalation are nebulizers or topical drugs are basically to go to a real specific area to work. I use an albuterol inhaler to open the air passages in my lung, for example, or a cream to basically fight an infection. Transdermal patches are also a very effective method. They do avoid that first pass, so they can be absorbed directly into the system. These can be used for a number of things, and the beauty of them is they have real long-term lasting effects. We see pain patches used very commonly. We've seen birth control delivered by this method. A nicotine patch would be another example. And those are going to be placed on an area preferably that is going to get the least amount of friction. It should be clean and dry, and ideally it should be moved periodically with each application. Those should be dated with date, time, and your initials. Ophthalmic is in the eyes. I think this is a challenging one. I usually find that it's easiest to have them close their eyes and then I raise their eyelid and instill it in the inner canthus and let them blink it around. That seems to work the best. And this is a demonstration. Otic, or in the ear, may be used for cleaning. It can be used antibiotic-wise for irrigations, etc. It is nice if they can lay down and lay on that unaffected side long enough for that affected side to really absorb it. You'll also often see them, doctors will suggest they put a cotton ball or a piece of cotton in there to kind of keep it. Nasal administration, again, often for a very local effect, often for a local astringent effect. These can be very addictive, and patients need to understand that a lot of times they become dependent on them, and then they have to pretty much wean themselves off of it. So they need to be aware of that if they are taking those. Vaginal administration most often is for suppositories or creams. Occasionally you'll see when we go into OB that they'll use it for some other medications such as Cytotec, which is a tablet. As we do this, I think it's always, your book points out that it's important to understand the purpose and treatment. I think that goes for all medications, but also to basically allow them to have some dignity. So, keeping that bath blanket as you're inserting it, etc., I think is a just a kindness for your patient. Rectal is usually suppository in form. This is used, I usually find, use my pointer finger seems to be the easiest. If you have particularly large hands, that's going to be a smaller finger probably, but in general that works out well. You need to get it up past that internal sphincter basically, and so it has to be up there before they're gonna, otherwise it'll just kind of come back out. It can be given as an enema, but probably more often in a suppository form. Again, it doesn't have to go through that first pass effect, and they don't have the digestive enzymes to deal with as far as those drugs. That area, both the vaginal delivery and rectal, is extremely vascular, so it does tend to work very well. Rectally, a lot of times medications are given that way if they're not able to take something in a PO fashion. For example, if they have really severe nausea and vomiting, you're going to see that they're going to get a rectal suppository in, say, a Phenergan or Compazine to relieve that nausea, because they're not going to keep anything else down. Parenterals are about intradermal, subcutaneous, intramuscular. We've really covered the intramuscular. Subcutaneous is going to be at a little different angle and size needle as is intradermal, and I'll plan on showing you some of that in the lab, but you need to know where to do that. Intradermal is between the layers of skin. This is clearly a technique. And again, I plan to show you that. Subcutaneous is really deepest layers of the skin and really the fatty tissue. And then intramuscular is specific muscles. When we talk intravenous, clearly we're going into the vein. These also avoid the first pass effect and digestive enzymes, and good for people who can't do things orally. So often you'll see your post-op patients while they're in the operating room, that kind of thing are all going to be done IV. Small volumes in general, injections, we have to look at volume as far as where we inject that. Intradermal is going to be very small amounts, like 0.1. This shows an intradermal, and you're literally putting it between the layers of skin. For example, this looks to me like a TB test, and what you're really creating is what we call a bleb. The angle is very slight. I don't generally put a Band-Aid over it unless it is specifically bleeding, just because the pressure of it, sometimes if you put it on too snugly, can actually kind of push the fluid out. So I don't generally do that unless they just want it. This shows you a subcutaneous administration. Usually I go more in the back of the arm, and it looks like that's where this person is going as far as delivery. I usually kind of pinch up the fat of it and give it at a 45-degree angle. You'll see that that needle is much smaller than what we use for an IM, so a 5/8 inch needle is pretty typical, and often a smaller gauge of needle as well, so like a 25 gauge is pretty standard. And again, depending on the med, is going to depend on whether or not Band-Aid on top. You see the administration person having gloves on. You will see that most often. You will be expected to do that as a student, but again, recognize that in some settings you will not necessarily see them always wear gloves, and that isn't necessarily a terrible thing. Intramuscular, we talked about pretty rapid onset as far as when compared with oral, intradermal, or sub-Q. We can give a much larger volume, often about up to a ml is pretty standard. If you get it much bigger, depends on the size of the person. Adult can get up to 3 mils in a large muscle, but 2 mils is really going to be about the standard upper limit. 1 mil is going to be the limit when we're looking at the deltoid muscle. So if you're looking at a greater volume than that, you need to go to a different, bigger muscle group. And again, that 90-degree angle is going to be critical. So make sure that you are achieving that when you give it. You need to make sure that you're in the muscle. So I have to evaluate each patient to really determine if that's the case. Again, giving the injection, aspirating appropriately, and then removing and putting the Band-Aid on. The common intramuscular injection sites we've talked about, and review all these. The biggest issue with IV medication is that while it does act very quickly, and that is often to our benefit as far as relief for a patient or treatment of some issue that they're having, it also has very swift effects as far as adverse reaction, and it's very, very difficult. You can't take it back, basically. So if there's an error made, or if a patient has a negative side effect to a medication, there's really not a lot that can be done unless we give them some kind of antidote. This just shows another way of giving a medication into a port into basically an IV solution. This would be via piggyback. We piggyback in often antibiotics. This is an infusion pump that basically is able to do a variety, as you can see, of different solutions at one time. We see large volume infusion, usually more for maintenance, for replacement purposes, or to supplement what they're already taking in, or intermittent. And oftentimes they will have antibiotics, for example, given intermittently every 8 hours, in which case they would have a saline lock-in or a heparin lock-in, and we just put an IV, basically put that in place when they are in need of that medication. IV bolus is going to be a push administration. They're going to get a large amount of fluid or a med basically at one time in order to have a rapid effect. Example of this is often an IV fluid. We would give a bolus of a fluid in order for them to have that therapeutic effect in a hurry. Port is cleaned. You may have a needle system depending. We give that to them via that port, and if they're already on a IV fluid, it's going to go in with that IV fluid. If we're giving it to them in a push situation, oftentimes that medication still has to be delivered over some designated interval, which we would find in our drug books. It does have the advantage of bypass of that first pass effect and any GI enzymes. Easy for those who are non-conscious or unable to take PO fluids, but the reality is that it is very immediate.